Hello, welcome everybody today, and I'd like to acknowledge the traditional owners of the land throughout Australia and their connections to land, sea and community, and we pay our respects to the elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. I'd like to welcome everybody to the fourth of four sessions today, this month, and this one is looking at the impact of COVID across the nation, and we have Rob Stirling and Rebecca Lang talking about the impact on non-governmental organizations, Sione Crawford talking about lockdown in Victoria, Nick Lintzeris talking about the impact on medication assisted treatment, and then we'll have a Q&A. So without ado, I hand over to Rob and to Rebecca.
Thanks, Michael. Thank you for the opportunity to share the results of some work we did with our member organisations earlier this year. I'll just start by acknowledging the traditional custodians of the lands that I meet on, which is the Yagara and the Turrbal peoples. My colleague Rob is on Gadigal land. We pay our respects to elders past and present. So the AOD Peaks network is obviously made up of the 8 state and territory alcohol and other drug non-government peaks. So we are all supported by the Australian Government Department of Health to do capacity building work within our relative jurisdictions. So we represent approximately 435 organisations providing treatment across Australia. Our membership covers all specialist treatment types, and we are a significant provider of alcohol and drug treatment services, providing 71% of all treatment episodes in the 18-19 financial year. The survey was developed in consultation with both the Department of Health and amongst the Peaks network to attempt to quantify the impact that COVID was having in the early stages on both service delivery and on worker wellbeing amongst our member organisations. The questions were mostly focused on what had changed, how easy it was to change, what were some of the pressures that people were facing, and so that we could quantify our advice to government around support they could provide. And it was conducted during May and June, so quite early in the trajectory of the pandemic. We had 210 responses. I think we were all really pleased to see that we got significant participation from regional, rural and remote areas, which are traditionally hard to kind of engage in these types of processes. The majority of respondents were from non-residential services, although I would just note that there is a portion of our sector that provides both residential and non-residential services. So all service types were represented. The results around reported change in demand, we landed on thinking that it probably just reflected the chaos of the early pandemic times. So there was essentially equal numbers of people who said that demand had increased, or that there had been no change, or that it had decreased. And then there were some people who were just unsure one way or the other. So when we looked at the increases, it did seem that it didn't have any particular pattern across. There wasn't a particular jurisdiction where demand increased more than others, for instance. So this kind of trend of no trend was consistent across the country. And where demand had shifted up or down, the reports that people were giving us were wild fluctuations in terms of the impact on their own services. What we did discover was that, unsurprisingly, about 80% of our treatment providers that indicated that they had shifted from face-to-face delivery to either online or telephone digital health, and that for the most part was essentially all of their service delivery in the early stages. The interesting thing was that some of the changes were considered to be useful changes. And so we had nearly 8 in 10 respondents indicating that they wanted to continue some of the changes after the pandemic, which essentially was about providing options to clients to engage via telehealth sometimes and face-to-face other times. And I will now hand you over to my colleague Rob to dive into the residential and non-residential findings.
Thank you, Beck. So for non-residential services, you can see that just over 40% reported that there was no change. And we can assume that for those services, they were providing the equal amount of services that were face-to-face to online. We did see almost a quarter report increased number of appointments being offered, and equally a quarter reported a reduced number. So for those that reported an increased number, some of the narrative around what supported that was that the ease of rescheduling virtual appointments, time saved between travelling between appointments, and a decrease in missed appointments. And for those that indicated that they decreased appointment capacity, they reported reductions in groups, infection control measures, and reduction in access to clients in detention due to lockdown of correctional facilities. So for residential rehabilitation, you can see that almost 3/4 of services reported that they had to reduce their number. And that was to enable single occupancy in rooms, as well as concerns around sharing bathrooms. So you can see that almost 24% reported no change, and we can assume that that were probably services that already had single occupancy rooms, so they didn't need to make changes to their capacity. In terms of the increased costs that non-government services encountered was predominantly associated with technology, obviously moving people from face-to-face to online, supporting staff to work from home for the workforce. But then on the flip side of that, we also heard from services that were supporting clients to access phone and data plans to support use of technology. Access to PPE was a big challenge, and NGOs weren't able to access PPE through the public health systems across the country. Additional cleaning fees, particularly for residential services. And then 31% also reported reduced income from client fees, and that was for residential services. And that still continues today for many services who haven't been able to go back to normal capacity. In terms of workforce issues, 3/4 of the services reported that there were no changes to staff numbers as a result. There were some slight increases and decreases, predominantly with casual staff. And there were 13% of respondents identified issues with the workforce, such as increased use of sick leave, supporting staff with health vulnerabilities, and issues around transitioning staff to work from home. So the majority of our services reported increasing co-occurring issues, with almost 90% reporting mental health concerns, and then just over 50% reporting financial stress for their clients, as well as family and domestic violence, as well as comments relating to stress and anxiety, child safety issues, social isolation, and suicidality. In terms of the implications for practice and policy, so the majority of our services report that COVID had significantly impacted their services. However, the service sector really adapted to the changing environment. So whilst telehealth and digital delivery are providing a way for people to access treatment, it is unclear if this approach is reaching all people who need treatment, or if it is as effective as face-to-face service delivery. And we certainly heard from services that there was less engagement by Aboriginal and Torres Strait Islander people, cultural and linguistically diverse people, as well as other disadvantaged groups, such as those experiencing homelessness. So we believe that further research is required to understand the impact on demand and changes in treatment outcomes and experiences of care for virtual care. And finally, it is unclear about how these service delivery changes will be maintained post-COVID, and that will depend on the decisions of services informed by their client groups, as well as negotiation with their funders. However, what we do know is that the AD treatment sector has never been adequately resourced to meet demand for services, and this has been further impacted by residential services needing to reduce their bed capacity to enable physical distancing. And so whilst COVID has showed us that there's an opportunity to broaden treatment options through virtual care, which may also assist in supporting people on waiting lists and post-treatment engagement. However, this will need to be resourced, or we'll see reductions in face-to-face care. So we believe that there is a pressing need for funders and providers to prepare for an additional increase in demand for AOD services as the economic and social impacts of the pandemic progress. And of course, the PEAKS network advocate for a well-resourced and sustainable AOD service sector. And finally, we'd just like to thank the service providers who generously gave their time to complete the survey during very challenging times throughout May and June, and also our colleagues in the other jurisdictions. And the full report is available on the PEAKS websites or available upon request. There's our email address, but we'll save questions till the end. Thank you.
Thank you both, Rebecca and Robert, for that fascinating presentation. Now over to Sione Crawford.
Thank you. Thank you for that. So I too would like to acknowledge the traditional owners of the land that I'm on today, which is the Wurundjeri Woi-wurrung people of the Kulin Nation here in Melbourne. So I'll just work out how to move things. So today I won't have time to focus on all the issues that have come up for people who use drugs in Victoria over the lockdown. I just want to focus on a few that have really popped up and probably underline some of the stuff that Rebecca and Rob have already talked about as well. I think it's worth just going over a little bit, at least putting up on the screen and going over a little bit what the experience for Victoria was throughout the lockdown. I won't go through the whole timeline, but it's up there. I think the headline to the right of the slide there sort of sums up very much how a lot of people in Victoria felt as we headed through July and into August this year, as it became pretty clear that we were heading for a bit of a bumpy ride over the next few months. And I think that really it's hard to overstate the sense of fearfulness and uncertainty that existed for people who use drugs in particular, as we saw our opportunities and freedoms really to be in the world more and more restricted and more coming under police and public health regulations. I think that was really sort of the most dramatic experience of that for a lot of people really was when the 9 public housing towers in Flemington and Kensington, just near where Harm Reduction Victoria is in North Melbourne, were locked down. We had a number of our community live there, and over 3,000 people were given less than a couple of hours, well, less than actually no notice that they'd be detained, completely detained to their homes for a really, although the time was specified, it was clear that it was going to be longer than a couple of days. So really, when the state of disaster was brought in, the stuff that really impacted on people who use drugs in particular in our community were same stuff that affected everyone, but as we'll talk about as we go along, we were a bit more over policed. But that was really the curfew, where we couldn't leave home after 8 o'clock, couldn't leave home at all unless it was for a so-called legitimate reason. There were 4 of them. Buying drugs was not one of them, and there was, and as I'll talk about, there was confusion about what that meant. We also couldn't travel more than 5 kilometres, which impacted a lot of people who use drugs. Immediately, however, back in March, it became clear that a digital divide was probably going to occur for our community as services moved to remote, to working from home and remote service provision. Our organisation in particular, peer-to-peer work in particular, was affected dramatically, and in particular engagement and trust building activities were affected. So a lot of our community, not all of our community, but a lot of our community lack IT capacity or data. Having said that, there were natural networks of people who use drugs who have continued to support one another all the way through the pandemic, from March right through to now, including our amazing Dancewise crew, who already had a great online and digital footprint, and they have worked assiduously to sort of to improve that and to utilize that way of connecting with their community, using videos, online meetings and online education and so forth. Our peer distributed NSP workers also continue to deliver needles and syringes to their networks right throughout the pandemic as well, and we were able to do some overdose and naloxone education online. But clearly it was actually very unclear for a lot of people in the community about whether or not access to NSP and harm reduction was considered to be part of accessing healthcare, and it took some time to sort that out. So really what has one of the key things that's happened, I think you probably will all be aware of this, but it's worth underlining, is that we've got a very disrupted market drug-wise now, and all the way through, really from early days in the pandemic. In Victoria, certainly, we've had ultimately drug prices have gone up and quality has dropped dramatically. In particular, that's the case for heroin. The meth prices have increased, but meth quality has actually increased for some people. But as we'll see throughout this talk, it's been a really uneven effect on the community. So some people have had the effects of the pandemic, and the effects of the disrupted market have been different for different people. So another sort of interesting thing that has come up, and is just a marker of a disrupted market really, is that we've noticed an increase in GHB use, as have a number of NSP services as well, being used by people who haven't traditionally been seen to be users of that substance. There was an NSP Snapshot Survey undertaken across a number of months throughout the pandemic, but this particular one that I'm showing you was from the first 3 weeks of September, when the stage 4 restrictions really were biting. This was put together by 5 NSPs and created at the Burnett Institute with Paul Dietz and Michael and Penny. And really this just highlights what I was essentially saying in that last slide, which is that the impact of the restrictions has been different on different people. So but a large proportion of people had noted that their drug use had decreased, and a large number of and nearly half of those people whose use had decreased were unable to afford it, but a substantial number were also unable to travel to their dealer as well. For those who had whose use had increased over these 3 weeks, or at least self-reported use had increased. Sorry. One of the interesting figures on this chart shows that 30% of people who increased their use stated it was related to drug quality. So one of the issues about a disrupted market really is that as we move into the next few phases of our journey through this pandemic, we really need to be certain that people like this are not caught unawares by quality increases again, because that's really a great opportunity for overdose, unfortunately, is when quality increases are not, when people don't know about it, or have maybe done some other activities to potentiate their opioids and continue to do that. And as opioids become higher quality again, then that's clearly something that organisations like ours need to be able to communicate to our community, as do all services as well. Within the pandemic, and I'm just look at my time, within the pandemic, we did a number of consultations, and I won't go through the whole slide here, but one of these consultations with around 30 people relatively recently, towards the end of the stage 4 lockdowns, really had a couple of things that jumped out at me. I think, just to underline what we said before, is that for a sizable minority, they felt that COVID had not actually made much of a difference in terms of how they would access support. So one of the reasons for that is because they feel like they're already sort of self-reliant and resilient, and at the best of times, they don't feel supported by our treatment services or our systems anyway. And so, for instance, one person, the thing they really want, they can't get, whether it's COVID exists or not, and it's a heroin prescription program, as an example. We had some OST restrictions, and like a lot of the country released a little, lightened a little bit, and these were very welcome, as you'd imagine. But interestingly, another thing that came up through our consultation was that some people absolutely assumed that the OST changes, regulation changes, were about keeping services safe and not for our benefit. It's hard to argue that it wasn't about both those things, but it's just interesting that that is the way that our community, a number of our communities sort of saw changes, that even something that benefits us seems to have a double-edged sword to it. Double-edged sort of, it's hard to accept it as being for us, I suppose, is a way of putting it. And really the last point I want to make is that our community is already over-policed, and throughout COVID we were over-policed, I think. So the same NSP Snapshot Survey that I referred to before. Also asked people about whether or not they had been fined through the stage 4 restrictions. And I won't go through all the numbers, but you can see up on the slides there that a sizable minority again were fined and some were arrested during the lockdown for a range of things, including the breaching the public health restrictions, like breaching a curfew, being out of the house for a non-essential reason. Of the 110, which is around 10% of the people who responded to the survey, who received 110 of the 1,000 odd people who did the survey had received a fine for breaching restrictions. Over the whole course of the pandemic, 19,000 or maybe a bit over 20,000 now fines were given out across the entirety of the pandemic. So if, and that's across 4 million Melburnians, broadly speaking, most of the regions were left out of this. Had that, I don't have to do the math, but had we all been fined at the same rate as NSP clients, that would be sort of much more along the order of 400,000 fines rather than 19,000. There's a lot of complex reasons for why our community were fined. As I say, we're already over-policed and people really basically just had to be out and about, getting their drugs, making money, doing all that sort of stuff that we have to do day to day. COVID didn't change that, unfortunately.
Sione, thanks very much.
All good.
Thanks very much. Much obliged. Very interesting to see and to see the picture, and best of luck in Melbourne. And I know that Nick Lintzeris has been keeping an eye on what's happening in Melbourne as we switch over to talk now. Over to you, Nick. You're muted.
Yeah. So can people see my screen?
Yes, we can.
Okay, lovely. So I'm going to be talking about some of the impact of COVID upon opioid treatment in Australia, but the focus to a large degree about New South Wales. Not just really about what's happened, but more importantly, I want us to start thinking about what comes next. How do we learn from these experiences and what might a new service system look like? So I'll talk about some of the changes that happened to opioid treatment. I'm going to use some of the data we have available from South East Sydney Local Health District, which is the service that I'm the director of. We've got some sort of more in-depth data there that we can talk about, and really just serves as a case study. And then look at some of the important questions I think we need to confront as a sector about what happens next. Do we snap back to pre-COVID models? Do we consider alternative approaches to how we provide services? And ultimately, the real questions about who makes these decisions and how do we make these decisions? Quick snapshot, 51,000 clients accessed opioid agonist treatment in 2019. 65% of clients are treated in the private system, about 27% in public and 7% in corrections. You can see the huge diversity. At one end of the spectrum, there is Victoria with no public treatment available. At the other end of the spectrum, you have Queensland, where over 50% of treatment is provided by the public system, and most jurisdictions sit in that about a third or so of treatment is being provided by the public system. In terms of where a client's dosed, again, there is variation from state to state, but overall you can see 70% in community pharmacies. In clinics make up 15%, either public or private, and the private clinic system is a New South Wales only model. Corrections form a group there. The medications, methadone is by far the predominant model, although it is dropping. It was about 70% 10 years ago, and it is reduced to 60%. And this is before the advent of depot buprenorphine. So there's already a slow shift has been occurring there. And as we all know, that we have predominantly a supervised treatment model in Australia, and that means that the Commonwealth pay for the medication. State governments pay for public clinics and for corrections for the cost of dosing there, and in the private system, that is largely borne by clients, the cost of that. So the challenge of COVID, many of you know these things, we had to reduce the need for daily attendance and congregation of clients' services and all the issues around travel and so forth. There were concerns obviously about the increasing vulnerability of our client population, both in terms of age and their comorbidities, but also the social conditions, things such as housing and access to healthcare and so forth. There was also recognition that there was an increased demand for opioid treatment. Other forms of treatment, as Rob and Rebecca highlighted, residential treatment became patchy, inpatient hospital admissions became patchy, and the prisons started releasing lots of people from custody. And there was also disruption of the drug distribution network. So all this created the recognition that we were going to have to continue to maintain, if not expand, opioid treatment. And there were also issues for our staff. We also have aging staff, safety issues for staff, and there are also vulnerable workers, so workers who also had their own health issues to address. So the goals of the changes were these 5 points, and I can fully appreciate where Sione is coming from and where, you know, there were multiple reasons for making these changes. They weren't only for client benefit, but clearly client benefit was one of the key factors here. So one of the most important things was actually preventing the spread of COVID amongst clients, staff, and their social contacts. I think that's really important. We had to make sure the continuity of treatment was maintained. We had to promote client safety and well-being, staff safety and well-being, and ultimately also think about how we could minimize harms to the community that can occur with opiate agonist medications, in particular with takeaway medications. As we know, not a lot of people overdose on methadone or buprenorphine of those in treatment. The real risk is for those people not in treatment and accessing other people's or using other people's methadone, to a lesser extent buprenorphine. So that was one of the challenges we also had to address. So what were the kinds of changes? Well, there was some national guidance. This was a document that was very rapidly put together by with some consultation and endorsement by key doctor groups, nurse groups, pharmacy groups, consumer groups, APSAD, and the Pension Institute, and that was released very, very quickly. So this was out soon after Easter, so it was within a couple of weeks of COVID really hitting our services, and there's a website we can get that. The key recommendations now I also have to emphasize that was a national kind of recommendations. Several jurisdictions put out their own recommendations and guidance. I know Victoria, New South Wales in particular were very quick off the mark in releasing guidance. Some of the other jurisdictions to this date still have not actually made any formal recommendations around changes to COVID. But the key kinds of changes that we've been seeing in all these documents and all these kinds of recommendations is the need for less supervised dosing and increasing takeaway options, the importance of looking at how we can have less direct patient contact, so more telehealth, less things like urine drug screens, breathalyzer testing, those kinds of things, and increasing availability of depot buprenorphine, which only requires contact with a client once a month, for example, in most cases. We also had to supercharge take-home naloxone as we were giving more takeaway doses. There was recognition of the need to make sure the take-home naloxone was available in the community. And we also had to think through strategies about how would we continue treatment continuity for those clients who are in isolation or quarantine. Sione gave the example of the towers. We had similar experiences here in Sydney as well, where there were lockdowns, and in some instances there were dozens of clients stuck in areas where they could not leave to access their medication. So they're the kinds of recommendations, but what really happened, and I think it's important to recognize, we don't really know what's happened. So that's for a number of reasons. Things happen very, very quickly, and there's a very diverse service system across Australia anyway, and we haven't really had the opportunity to, carefully design evaluation systems before all this happened. So a lot of it has been retrospective, trying to sort of figure out just what did happen. Different jurisdictions implemented changes in different ways. There's also marked differences between what the private and public system does, and then also big differences in corrections, and also big differences in the impact of COVID in different jurisdictions. So I've experienced New South Wales and Victoria Victoria in full lockdown, and very different to what's been going on in some of the other jurisdictions where they've kind of viewed COVID as something happening, you know, in Melbourne and Sydney, not really impacting upon their local services. So how can we try to make sense of what has happened? Well, I'm going to give the example of Southeast Sydney as a case study, and I want to acknowledge a whole bunch of people that have worked on the data that we have available. For those of you unfamiliar with Southeast Sydney, we have 3 opioid treatment services, about 500, 550 patients at any one point in time. There's the Langton Centre, St George and Sutherland. They are multidisciplinary teams with nurses, doctors, allied health, and we also employ consumer workers. They are part of our staff and they're an essential component of our services. The timescale you can see there, things happen very, very, very quickly. So, you know, we were making changes to service systems and procedures within matters of days and weeks. Things that normally would have taken us 6 months to 2 years to go through normal governance processes, we were having to turn everything around within a matter of days. Very challenging for everyone, but somehow I think, you know, as everyone knows, I think everyone was challenged during those heady days. So how will we be able to evaluate our services? Well, one of the things that we've been implementing and putting a lot of time in Southeast Sydney and the rest of New South Wales Health is looking how we can better leverage our routinely collected data that is extracted from our electronic medical record systems in New South Wales Health Services. That New South Wales provides around 70 to 80% of AOD treatment in New South Wales. Is largely all linked in through a consistent electronic data system called CHOC. It allows us to describe who are the patients, what do they look like, their patterns of substance use, and also the services that were delivered. And we were able to look at the window before and after COVID, and also look at some of the experiences of staff and clients. For those of you unfamiliar with it, I won't go through it, but ATOP was one of the key tools that is just routinely used in our service system. That's the flow of clients. Anyone interested in that can have a look at it sort of at a later time, but basically we've got data on around 400 odd clients. So who were the clients? They're the ages, gender. You can see about 20% of clients are identify as being of Indigenous background, and in Southeast Sydney, predominantly English-speaking Australian-born clients. ATOP data tells us that pre-COVID, this is all pre-COVID data, it was a minority of clients reported any work, only about 13%. Similar proportions reported being homeless and 5% at risk of eviction. So, you know, you're talking about almost 20% of patients have got housing stress. You can see there, and violence reported in about 5 to 10% of our clients. When we look at some of the issues around patient reported or client reported health status, about a third of clients reported that they have sort of poor psychological health. About 28% reported poor physical health, and 27% reported poor quality of life. I won't go into the metrics about how we do that, but it all comes from ATOP data. So what happened in the way we delivered treatment? This is looking at data before and after COVID, pre and post. You can see the numbers. We had about 400 before and around 300 plus afterwards. You can see the changes in the kinds of treatments that were being prescribed. Not much change in the methadone. That stayed stable. That's this group. There was so total buprenorphine stayed stable, but you can see there's a marked shift from being predominantly sublingual pre to now depot buprenorphine is the predominant form of buprenorphine treatment provided in our services. Look at the takeaways. We went from 2/3 of our clients receiving no takeaways and only 5% getting high levels of takeaways. That's 6 or more a week. So that could be up to monthly for buprenorphine, for example. And you can see what happened afterwards. Only about a quarter of our clients were getting no takeaways, and a pretty even spread across so about a quarter of our clients are now receiving weekly or more takeaways in our treatment. We'll look at that in the next slide a little bit more. And where were clients being dosed? pre. So if you take out the depot clients, and we'll talk about depot later, basically we had a quarter being dosed in the community and 3/4 in the public clinics. And that now has roughly equaled out to about 50-50 split between community and public sector services. So you can see there's been some marked changes in the way services have been provided. Just want to break down the issue around takeaways, because I think takeaways is a critical issue about how we deliver treatment moving forward. So you can see the differences there between methadone and buprenorphine. With methadone, again, there wasn't a lot of takeaways pre. 21% were getting any takeaways and no one was getting weekly or more. You can see the changes now in our takeaway systems. You can see here that now 20% of our methadone patients are picking up once a week or less. About half are getting some takeaways and about a third are getting no takeaways. Look at buprenorphine. We predominantly use Suboxone in our services. Now, 2/3 of our clients on Suboxone are picking up weekly or less. So this is a marked shift in the way we deliver treatment. What happened to substance use? The only significant differences in the groups, a little bit reflective of what Sione was saying. You can see here that there was a significant reduction in opioid use. This is the proportion reporting any use in the last month. And of those reporting any use, how many days had they used? So what we saw here, you can see the trend here is a reduction, not so much in the numbers using any heroin, but a marked reduction in the days used. So heroin became more difficult to access or use. Not much change in alcohol, a bit of reduction in stimulants. You can see there in the proportion using. Benzodiazepines similarly. Cannabis was the only drug that markedly increased in terms of proportion of clients. And we've seen this in some of the other households or some of the other surveys that have been going on in non-treatment populations, how cannabis use seems to be the drug that many people have turned to for a whole variety of reasons. It seems to be a good social lockdown drug. Now, those are group differences. They don't really allow you to sort of look at what happened to individual changes. This is a complex graphic. I won't go into it all, but this is basically looking at those people who were not using much opioids in the pre-COVID period and what happened to their patterns of substance use, of opioid use. You can see here that the majority of people who weren't using continued to not use, some stayed the same and some reduced even further. There was a small group, 6% of the clients who were not using much increased their use. And of those who were using a lot of more frequent heroin use in the period before COVID, what happened to their patterns? You can see that the majority of them reduced their use. Some stayed the same and a small group increased. So overall, when you combine this, it actually turned out only about 8% of our clients reported an increase in opioid use over that period of time. What happened in other health parameters? Overall, it looks as though there was no major shifts. If anything, psychological health, slight improvements in terms of self-ratings. But again, if you actually break it down into a little bit more nuances, look at individual changes, those who were sort of saying that they were traveling well before COVID, about 20% of them reported a significant reduction in their mental health. Most people said no major changes, and some said they had a bit of improvement. Of those who were reporting not traveling well before COVID, if anything, actually there was more improvement than anything else. So again, what we're seeing here is a diversity of outcome. Group data says not much change, yet there is change going on at individual levels. What are some of the changes in our models of care? So one of the key things was take-home naloxone really got supercharged. Our services were at the forefront of rolling out take-home naloxone in New South Wales and across Australia in terms of opioid treatment services over the last 5-6 years, yet we saw it supercharged during the time of COVID. So basically every client got naloxone, both Nixoid and Pranoxal was being provided free of charge, and was actually being supplied directly to clients by our nurses, allied health and consumer workers. I think this is the first time actually in Australia that consumer workers were actually able to supply drugs without having to have a nurse, a doctor, a pharmacist or any any other health professional involved in supplying the naloxone. So that was really exciting. We pretty much reduced doing urine drug screens and breathalyzers from routinely to now only as clinically required, and that was a marked reduction. Telehealth worked well for casework, but you know, I think it's fair to say that some of the longer consultations, the counselling type work, didn't really work well in this population with telehealth systems, and a whole bunch of reasons we can talk about there. Perimeter screening. That meant, you know, everyone was having their temperature checked, surveyed every time they entered the buildings, staff and clients, mask wearing. This placed a huge burden upon our workforce. Home visits, we were doing 2 to 3 home visits every day, delivering methadone or Suboxone to patients who were stuck at home and unable to get out. We also started working much more closely with families and carers for them to be able to be involved in dosing and supervising medication. So where a client themselves may not have been in a great position to be able to you know, control all their medications, often carers and families were able to step in, and that was fantastic. Huge increases in depot, but we also started seeing lots of methadone patients wanting to move over to buprenorphine. So we did a lot more methadone to bup transfers, and we started doing methadone to depot direct transfers. So patients on methadone being on a depot buprenorphine injection within 48 hours. So that has been exciting, and we want to do more work in that. And it really highlighted the importance of consumer workers in our services and the importance of leadership in our services as well. Other outcomes, similar to what other people have been saying, client experiences. Overall, the changes were generally positively received. However, for some clients, this has not been a good time. Social isolation, for many, going to the clinic or the pharmacy was their only time they got out and saw people. So for some people, it's been pretty isolating. Domestic violence is also an issue for some. Housing overall got really complicated. We've seen this paradoxical effect on finances, reduced substance use, reduced going out, increased income with JobSeeker and JobKeeper meant that many of our clients actually said their finances had never been so good. However, we all know that is very uncertain as to where that's going to end up. And a lot of the moving out to community pharmacy from the private clinics was pretty much predicated on increases in job seeker allowances. So what's going to happen once all that dries up next year remains to be seen. Were there harms associated with the changes? Well, some clients dropped out. To what extent was that COVID related versus just, you know, some clients just drop out of treatment? We want to explore that a little bit more. Some people were not able to maintain their takeaways safely. There were some overdoses in some of our clients, and we had to pull back on takeaway conditions for a minority of our client group. We didn't really see much evidence that we were seeing overdoses in our ED departments from people using diverted methadone or Suboxone. So that was encouraging, but anecdotal. We haven't done the systematic data linkage yet, and that remains to be seen. Impact on staff, I think it's fair to say we are all exhausted. It was thrilling, it was invigorating, but it just feels like, you know, we've been on a 3-day ice binge. We are exhausted, and you know, everyone's trying to catch up on annual leave and so forth. The huge impact on workloads, and some staff were not able to continue frontline roles. So there were staff, we have an aging workforce with their own health issues, with their own carer responsibilities, and it really placed strain on the service system. Are we achieving the goals that we set out? If they're the goals on the left, to what extent are we achieving them? Yes, sort of. You know, we only saw 1 case of COVID in our 500 odd clients. That was a Ruby Princess related case. Fortunately, that patient was on depot buprenorphine and actually contracted COVID and cleared COVID in between having to turn up for depot injections. So absolutely no impact for the client on in terms of their treatment or services. We were able to maintain continuity for most clients, but I think it's fair to say some clients fell between the cracks. Likewise for safety and well-being. Overall, traveling well, but you know, some people have not done well through this crisis, but into staff as well. And so far, it looks as though we have been able to minimize harms to the community by having the increased amounts of methadone and buprenorphine. More importantly, what happens next? What is the new COVID normal for opioid treatment? Do we just simply snap back to where we were, or do we pause and think about alternative approaches? I just want to actually talk about some of these issues. The first is supervised dosing and dispensing fees. Now, we've just seen in many jurisdictions a relaxation of takeaway doses that generally has resulted in positive outcomes for most, but not all people, with little evidence of community harms. So, what do we do with this information? This has been a natural experiment forced upon us. What should be our approach moving forward? Well, the changes that we saw during COVID, things such as less substance use, continue. Or once COVID changes relax, will some of those changes, also wither, and we start seeing different patterns of substance use. So the experiences of the last 6 months may not actually be the experiences moving forward. Income support for many clients probably won't be sustained beyond 2021 if we believe our governments. And what is the role of public clinic dosing? Is a public clinic there to do long-term dosing for a few clients, or is it really should it be time limited, allowing greater access for those most in need at their times of greatest need when they're entering the treatment system, and then they should be sort of moving on to allow the next wave of high risk clients coming through. This is a question around how do we ration resources in healthcare, and how do we make sure that that is equitable? This is a discussion that we've rarely had in the public system in New South Wales. And the other key question I want us to think through is it time to decouple methadone and buprenorphine treatment? Australia pretty much, and I was largely one of the people responsible for this, we really bolted buprenorphine treatment onto methadone. Back in the early noughties, about 20 years ago now. So we basically took the methadone model and bolted buprenorphine on. That, however, has, I think, led to some issues. So whilst with methadone, we appreciate that takeaway doses is always associated with pharmacist labour and costs, and that there are overdose risks in non-clients using methadone. Many of those issues just do not apply with buprenorphine. So you can give weekly and monthly takeaways of buprenorphine without huge pharmacist labour, and hence without huge costs to clients. And the risks from overdose of diverted buprenorphine is much, much less. So is it time for us to rethink what we're doing with sublingual buprenorphine in this country, and perhaps start aligning it with what the rest of the world has been doing for the last 20 years, such as America, France, and the UK, which is have predominantly an unsupervised model of care. You may supervise treatment for a week or so, but then really you move on to unsupervised, and then all the implications of reduced client and staff burden. That's one thing that I think we need to have that discussion in Australia, which to date we have not really been able to have for a whole bunch of reasons. And I think also we need to pause and think, it's not just COVID. It is time for us, I think we are at a crossroads. COVID is just but one of a series of new challenges. In New South Wales and in other parts of Australia, we have seen bushfires and floods and pestilence, and there's refugees coming in who do not have access to Medicare systems. So there's a whole range of issues. It's not just about COVID anymore. And the vaccine is not going to take away all the challenges from COVID. So, we will see second, third waves as economies have to open up, as we open up our borders back to people, from overseas in order to stay economically sound. We will see new waves of COVID. So it ain't over, folks. And the vaccines aren't going to fix everything.
Nick,
so, yep.
Thanks very much.
And then can I just put up the last slide,
okay.
Which is most of our models of care have been built upon tradition, business models, some state regulations, and lots of guidelines with people bluffing that we have to stick to the guidelines, historically little monitoring. Do we need to have, does everyone need to be doing the same thing? So if Tasmania wants one approach, but New South Wales wants another approach, for example, around supervised dosing, who says we need to comply when actually all the regulations are state-based, not Commonwealth? Do different practitioners need to stick to the guidelines when in fact that's not what we see anyway? There is huge diversity between private and public sector, and ultimately who decides and how. And that's where I think we need to start rethinking about the discussions around how we do this kind of treatment decisions in the future.
Thanks very much. Thanks very much for that, Nick. Now I'd ask our other speakers to come online to put their cameras on again. And so we've had a broad sweep both across the country and across some of the treatment modalities. And we've heard about the requirement for new resources in the AOD sector and new ways of thinking. I'd like to open it up to people to see how we pull all of this together, and maybe start with Rob.
Thanks, Michael. Well, I mean, I think we talked about some of those questions before in terms of what we learn and how we move forward. And I think Nick talked about, I mean, I think looking at our client outcomes and the experiences of care data. So I hope that some of the non-government services anyway have an opportunity to shape the way they transform their services to adapt and be more person-centered. But again, the non-government sector relies on funding through government. So again, it'll be part of that negotiation process with funders. So it would be good to have funders' views as well in terms of where they see the AOD treatment sector going, not just funders, policymakers as well.
Rebecca, would you like to add anything to that? You're on.
Only to say that I just really agree with Nick, the point that Nick made around the rush to flexibility that would have taken a really long time in any other circumstance, but actually demonstrated that maybe we're all a little uptight and should relax a little bit about some of this stuff, that actually people who access our services for the most part do have quite a lot of resources. I think about Sione's presentation, thinking about the resilience of particularly long-term opioid users in terms of negotiating their way through society. So I think maybe we should learn to trust our client base a little more, and to really bring them into the conversation about our development of service models to make sure that what we're offering is acceptable to the people we purport to serve.
Thanks, Rebecca. Now, Sione, Nick made a considerable emphasis on the potential role of the consumer involvement in those service changes. Would you like to, and probably that, and also a bit, how does some of the stuff from New South Wales resonate with your experience in Victoria?
Yeah, I think it's really interesting that, first of all, just to relate to that last point, nearly all of the data that Nick presented, I was nodding along to, because just our very small consumer consultations basically said almost exactly what he was talking about, just in terms of maybe at a broad level, it doesn't look like a huge amount of change, but at an individual level, there's a lot of stuff going on for people, and people responded differently to it. And so we have to sort of, I think, taking both a micro view and that big macro view at a population level will be really important moving forwards. And I know that we're doing some there's the DHHS here is doing a rapid review around the OST, the impact of the OST restriction changes, at least the things that the state government can more responsible for. And but then on the end, so that data is to come. I would agree fully with Nick that actually, so one thing, the only thing I didn't really say in my talk was that actually, it's the next few months that really we have to be very watchful for, I think. And in that, I think consumers are a really important component. And I've watched, Cecily utilize consumer workers more and more over time, and watch that grow. And it's been, it's an awesome model that they have going there. And I think that, really, I just underline what Nick said, which is that the things that consumers can do and talk about are quantitative and qualitatively different, to service providers, and we just need to, use all of our tools and imbue that trust in people as well, where possible, where it's warranted.
I think the other thing I would say, Nick, is that you have a bit of a classic paper there. I know it'll be a problem around the COVID variable, But in relation to the question of the impact of takeaway versus non-takeaway, that shift, you've got a before and after natural experiment that will be of great international interest, you know.
I mean,
So,
yeah, look,
well done.
it's the importance, and I know groups like, you know, Robert Nard has also been thinking about this as well, about how do we embed, how do we use our embed our information that we collect as part of routine care. So one of the nice things is we've got a before and after snapshot here, but we've got historical before and afters as well that were not COVID related, because there is always churn and change in a clinic. Some patients are always doing better and doing worse. We can actually see, was there more better and worse around COVID than we would normally see during any sort of 6-month sort of change. So a lot more data will get unpacked. But I just want to also pick up on some of the comments that Rebecca and Robert and Sione. Look, I think every now and then things come along that, you know, disrupt service systems and disrupt the way we do our work and we do our business. And I think depot buprenorphine is a major disruptor in the way we think about opioid treatment. There's a whole bunch of issues there about the role of the private system with depot, but, you know, that's for another discussion. But I think COVID in particular also potentially is a disruptor. So some of the services that may have been world-class at delivering one model of care may actually be able to be more efficiently done through alternative service providers. So do we start thinking about, we're going to have, you know, 30 different telehealth providers? Or can you do, say, what Victoria has done, predominantly with a turning point type model, where you create one super mega telehealth provider for counselling? This, you can see, has huge implications for efficiencies. You don't want to lose the local, but there are efficiencies of scale as well. So I think the time, you know, I think there's going to be a lot of, COVID forces a lot of rethinking about what do we mean by treatment? What are the essential elements of treatment, and just who does it in the future?
Well, Nick, one of the things in that, and there's an article in the Financial Times today pointing out that one of the potential risks around remote services is worker disruption, because suddenly you can actually not have your workers in your service. They can be in some other part of the country. And we've actually seen that around, you know, international call services. And one of the worries might be that it actually becomes a significant factor in the future. But I think, that being said, we will wait and see. I think the times have changed. The only other thing I think we need to be mindful of in the coming few months is economic disruption, unemployment, and vulnerability around. Now, I know you presented a population who are not working, but there's a lot of people who are working who whose economic support will be disrupted, and the issues around that for the future. I think, I don't know, Rebecca, if you wanted to say anything about that.
Yeah, look, I think we're still in the very early part of this. I think anyone who thinks we've seen the worst of COVID is not watching what's happening in Europe and the United States right now. And while ever the rest of the world is kind of experiencing that level of disruption, it can't help but disrupt what we're doing over here. So, I mean, I'm really excited to hear everyone's got their thinking caps on about what we want to keep, what we want our system to look like. I think often we don't get those opportunities. So I think we've been presented with a once in a generation kind of opportunity to do something really great.
Well, look, I'm going to have to move on, but maybe we'll need a drug summit to actually come up with a new model, and actually genuine appetite for change and transformation. But before I finish up, I'd like to invite Leanne Hydes to say thank you, and also to comment on both the series and what's coming next year.
Hi everyone. I just wanted to take the moment to, on behalf of the APSAD, to thank all of the speakers who presented in our webinar series. We've had 4 of them within November. So there's been a lot of speakers and we're very grateful. I'm also grateful to Liz Baxter for organising everything, and also to Mike for chairing most of the sessions. And just wanted to quickly remind you that the APSAD National Conference will be held in Brisbane next year from the 7th to the 10th of November. We really got our fingers crossed that it's going to be face-to-face. We're really looking forward to catching up and seeing you all there. That's all. Back to you, Mike.
Okay, thank you very much, Leanne, and I'd like to thank all of you, all of our speakers here today. I think that this has been a fascinating session, and it's indicative of things to go to work on into the future. And wish you all keep safe, keep well, and hope to see you soon. Best wishes.
Thank you.